Prostate cancer is the second leading cancer killer in men in the United States. It takes the lives of nearly 30,000 men every year. So you would think, what could be simpler and more obvious than the fact that you need to do some sort of screening, and yet it's one of the most controversial areas in medicine. To try to figure that all out and make it clearer, I'm here with Dr. Herbert Leport, who's the head of urology for NYU Langone Medical Center and also a world's expert in prostate cancer and the author of a recent book on prostate cancer called
Redefining Prostate Cancer.
That makes sense. And I should say, in full disclosure, you are a colleague of mine at NYU Langone Medical Center. We share several patients together, and I've had the pleasure of learning from you over the years. Let's just start off. Why is there a controversy?
Well, before we had screening, basically prostate cancer was a death sentence, the diagnosis. So when the blood test PSA, it's only made by the prostate, so it seemed as though it would be the answer to help us identify earlier cancers. It did just that. But here was the problem. We got so good at diagnosing cancer, we were starting to diagnose those cancers that were not biologically significant. This is not like lung cancer, where virtually every lung cancer is lethal. The majority of prostate cancers, as they exist in the gland, are not significant.
And we're not gonna make everybody learn numbers, but we are gonna give them two numbers. I think they're important to just get the perspective. 16% of men are diagnosed with prostate cancer in their lifetime, about 16%. But only 3% of men actually die from prostate cancer. So the majority of men, as you say, don't. But those are the numbers. We're talking about a lot more people being diagnosed. And if you include people at autopsy, if you're 80 or 90, the odds of having prostate, little pieces of cancer in your prostate just at autopsy are greater than 50%, right?
So we just have to get smarter about screening. We don't go totally backward and say, let's abandon screening as the U.S. Preventive Service Task Force would recommend. But the other hand, what is done in clinical practice today is you get a PSA, it's elevated, it triggers one of these biopsies where you blindly put 12 needles into the prostate under ultrasound, and we now assume that we know the risk of the cancer that we're detecting. Because unlike pancreatic cancer or lung cancer, as the statistics show, many of these cancers are not significant prostate cancers, and they would be best not diagnosed.
All right, so clearly, this is going to be, in full disclosure, this is going to be the world according to Dr. Leport, because if you have 10 urologists, I think you may get 11 answers on this one. But let's just, for example, say I come in and I say, Dr. Leport, I feel perfectly fine, and I've just been told that my PSA is elevated. Normal's up to 4. Let's say mine is 7.
Right. So the first thing I would do is repeat it, just to make sure it's a real elevation. And we can't forget the digital rectal examination, although patients would prefer that you did, because there are some cancers that we can actually feel.
So you can people won't know, you can actually feel the part of the prostate through the rectum.
Where cancers are likely to develop. However, before we had that PSA, we were missing many of the lethal cancers, just simply relying on the digital rectal exam.
It was on the other side.
So what we have to do, as I say, we have to screen smarter, and I believe there have been real advances in imaging, in MRI, magnetic resonance imaging, so that what I would do, and I bet you we'll come back in a couple years, and that's sort of the message in redefining prostate cancer, because we gotta redefine it, because what we're doing today isn't where we need to be. That you're gonna get that elevated PSA, you're gonna confirm it, and then you're going to do an imaging study with advanced MRI. And if you don't see any abnormality, you will likely defer a biopsy unless that PSA keeps going up or there is a profound family history. On the other hand, if you end up getting an MRI and you see a discrete abnormality, the next thing you're going to do is, rather than do a blinded biopsy, you're going to do what we call a targeted biopsy, which means we're going to direct that needle into that abnormality rather than randomly into the prostate, where we're most likely to find what we call insignificant cancer. And if we do that, then what we're going to do is we're going to identify those cancers that need to be diagnosed and need to be treated, as opposed to all of those insignificant cancers that the current way we're doing things is leading to the detection.
There are a lot of people who, if the repeat PSA is still elevated, they'll say, could be prostatitis, an inflammation of the prostate. Let's just give you a course of antibiotics. What is your position on that?
I wouldn't do that, because what that's going to do is increase the likelihood when that patient gets a biopsy of leading to a life-threatening infection. So yes, you should repeat the PSA. That's without a doubt. But I wouldn't put in the antibiotics because they're likely to do more harm than good.
This is very controversial. One thing is very clear. We have not solved the problem, the huge problem of how to screen perfectly for prostate cancer. And in 10, 20, 30 years, they'll probably look back at us and say, I can't believe they were doing it that way. But that's where we are right now. Thank you so much, Dr. Herb Leport, for joining us today and talking about prostate cancer.
Thank you for having me.